Welcome. My name is Amit Achra. I'm an ID faculty here at Yale School of Medicine, as well as I work closely with Connecticut as Massachusetts Department of Health and Sylvia Tell STD HIV Prevention Training Center. It is indeed our pleasure to welcome you all to the Connecting for Sexual Health, the first of the clinical STI uh, CT STI Clinical Management Series, which is jointly planned by CT Department of Public Health STD Control Program, as well as the Sylvia Tile STD HIV Prevention Training Center. This series, as you all may know now, is planned for every Thursday for the month of May 2024. And we have a pretty exciting line of topics and speakers as they are listed in the program. Hopefully you've all seen. So this series is one of the many educational initiatives that we are planning in response to the rising STI epidemic, both locally and internationally even. And we hope that this educational initiative will improve your knowledge, confidence, and competence in diagnosing and managing some of the common STI cases, which we are now seeing being presented in any kind of clinical setting. It's kind of like when COVID pandemic hit, we all became COVID doctors, regardless of our primary practice. And I think with the STI pandemic, we are all now in some ways or form STI doctors. I think sooner or later you will see in your practice if haven't already. So yeah, we'll get started soon. As a reminder, you may type your question in the chat box. We will try to monitor as well as raise hand at the end of the talk. I think we'll prefer to address the questions at the end. The CME details will be provided as well at the end of the presentations. Finally, before we begin, I do also want to remind people this with this slide, the STD Clinical Consultation Network, which has been around for a while, but the usage I think varies. I think in Connecticut, we would prefer to see it being used more. So this is a portal or a platform which is actually funded by CDC and allows any clinician to ask any clinical question related to STI if you're not sure. And we basically discuss it and get back to you as soon as we can, STI expert panel. So yeah, do not feel alone if you are in a tough spot with any STI case. All right, with that, we'll begin. So today's focus, as you all know, is on syphilis, the great imitator, as we have all learned. Our first speaker is Eva Nepaul, who will be presenting some epidemiological data for first 10 or so minutes. And then we will hand it over to Dr. Dunne. Eva Nepaul is an MA, MPH. She's an epidemiologist at the STD Surveillance Coordinator at the Connecticut Department of Public Health STD Control Program. Ms. Nepaul is responsible for STI surveillance and partner services, data collection, management, quality assurance, and reporting. She has worked in the areas of TB control, outbreak investigation, health disparities, HIV prevention, asthma, and even cancer genomics. So very diverse experience there. Ms. Nepaul earned a bachelor's in human biology at Brown, a master's in medical anthropology at University of Amsterdam, as well as an MPH degree at UConn. And she's also a certified public health expert by National Board of Public Health Examinees. Okay, and then the next introduction I will just mention now, so we don't have an interruption between the talks, is my colleague and friend and a well-known expert on syphilis, Dr. Dunne. Dr. Dunne is the Associate Chair of Education in the Department of Medicine at Yale School of Medicine. She's also Associate DIO and GME Director for Educator Development. Dr. Dunne's clinical interests include HIV and STI interactions with specific concentration in syphilis. In fact, we candidly, I think she won't mind me mentioning this in public. We know her as a syphilis queen. So that's the title she has earned over the years, being an expert. She's a core faculty for the Yale Primary Care Residency HIV training track, as well as active in curriculum development and assessment. So yes, it is indeed my pleasure again to welcome you all and welcome our speakers. I will hand it over to Eva to get going. And again, feel free to type your questions in the chat or at the end. Thank you very much.
Okay, thank you, Dr. Char. So I have only about 10 minutes with you today, and there are a lot of slides. Now, rest assured, the slides that you will see today will be made available to you as a full PDF. I know that some of you really like to delve into those statistics, and I want to make sure that we have enough time for Dr. Dunne today to take you through syphilis. So I'll be just giving you an overview of what's going on with sexually transmitted infections in Connecticut. Okay. Will my slide advance? Okay, all right. So first, let's get something clear. There's been a lot of banter. STD, is it STD or STI? Guess what? We use both in the state of Connecticut. And for very different reasons. We do want to be accurate with STI, but let's face it, the lay public understands things as STD. And because our program focuses on not just enumeration of cases, but also on intervention to prevent other cases, we find that it's important to use both terms depending on which audiences we're dealing with. Okay. So I will be covering I will do an overview of what surveillance is for those of you who are not familiar with public health reporting. We'll also do a comparison of national and Connecticut statistics for chlamydia, gonorrhea, syphilis, and congenital syphilis. Okay. So in the state of Connecticut, like in other states, we are given statutory authority to collect certain pieces of information about diseases that are mandatory reportable conditions. So that means that any laboratories and any healthcare providers or any type of person that is licensed by the Connecticut Department of Public Health must, per the Public Health Code, report certain conditions, laboratory findings, and health conditions to us, not only as laboratory reportable findings, but also any providers who treat a person must also report to us as well. For STDs, we have a specific form called the STD-23. Some of you may be familiar with the PD-23. Please note that there are different forms for different illnesses, and we are working on electronic case reporting so that clinicians no longer have to deal with multiple forms for different diseases. Also, as a result of our being a grantee of the Centers for Disease Control and Prevention, we are allowed to share limited information on STIs with other states, other jurisdictions, and this helps us to make sure that we're following up on partners who may be living in another state. Puerto Rico is also included in our interstate communications. So this lovely jumbled slide just gives you an overview of what we do with all the information we get from providers, laboratories. Everything goes in through a platform called EDX, the Electronic Data Exchange, and into the Connecticut Electronic Diseases Surveillance System. From there, we not only have the lab and the treatment information, but also our disease investigation specialists who will go out and interview all newly diagnosed persons with syphilis or with HIV. They also put all of their information. So all this qualitative and quantitative information, required variables get sent to CDC. And then we also use all the information we're collecting to inform our education, outreach, and all of our messaging, including surveillance reports. And we are also constantly trying to make sure that our data are accurate and timely and represent what is going on really in the state of Connecticut. Okay. So the Centers for Disease Control and Prevention did publish the 2022 data in January of this year. And if we just look at national statistics, we see that overall, the unfortunate increase in congenital syphilis is continuing. Since 2018, we've seen a small decline in chlamydia nationwide, slight increase in gonorrhea, but syphilis is really taking over in terms of reportable STIs. In Connecticut, our picture is a bit different. You'll see that we've essentially had, since the COVID-19 pandemic, we've had a tripling of reported syphilis cases in our state. This is pretty alarming to us, and you will see why. Please note that there appears to be a slight increase in gonorrhea and an almost quarter decrease in chlamydia reports. There were some issues with our 2022 reporting systems, and so we know that there's an undercount of 2022 cases, and we're still working to address that. So I've just shown you a picture of the nation versus Connecticut, and I want to give us context so that we can keep everything in perspective. As much as we are experiencing this, unprecedented increase in Connecticut, we see here that the states with the highest American Indian, Alaska Native populations are blowing up with primary and secondary and congenital syphilis. And this is the rank of these are the state rankings for 2022. And we see that Connecticut ranks 43rd for chlamydia. And please appreciate the position we're in with primary and secondary and congenital syphilis. So it's very important to understand that while we are very alarmed, other states are really in crisis. Okay. All right, so briefly, chlamydia, you'll see here the artifact of the underreporting for 2022. But you'll see this increase here since, you'll see a little thing since 2015. And still in Connecticut, chlamydia infection is more common in females, almost twice that among males. For gonorrhea, what you see here is a sharp increase in 2015. Now, I will say that some of this, what you'll see around 2019 and nationwide, there was FDA approval of extragenital testing for gonorrhea in 2019. So we're getting greater opportunities for detecting as well as treating gonococcal infections of the rectum and the throat. All right, so we are still working on updating the gonorrhea case counts. The preliminary data that I do have show that it's about 50% female, 50% male. We are expecting to get a more increased number of males detected. Sorry, I just saw I had a typo. I got distracted for a moment. So let's talk about syphilis. So when we look at all syphilis, that means primary, secondary, early, latent, late latent, unknown duration, and congenital. It's pretty obvious what's gone on and continues to go on. Okay. And we see that we mirror the national trend. Again, some of this is undercount because this is just split out into primary and secondary syphilis. All right, so we are still seeing that most cases of primary and secondary syphilis occur in men who have male sex partners, but the heterosexual transmission is also up. Okay. Which brings us to congenital syphilis, which is a preventable outcome, and its occurrence is evidence of multiple missed opportunities and the intransigence of cumulative social disadvantage. Here we see, since syphilitic stillbirths were made reportable nationwide in 1941, there were some adjustments to the case definition, but the take-home message here is that nationwide, we are seeing this steep increase in congenital syphilis, right? And it's not looking good. If you just check this roughly, this peak against that peak, this is where we had our syphilis elimination committees in the 1990s. And this is the crack epidemic, which also contributed to that peak that we saw in the 90s. So it appears that we're heading to similar levels. All right, and not surprisingly, that's happening because we're seeing syphilis increasing in women of childbearing age. So it makes sense. In Connecticut, we hadn't seen a congenital syphilis for some time, and then we had one in 2015. In 2018, we had one live birth and one stillbirth. And here we are, 2021, 2022, still going up. We started active surveillance in April of 2022. So we're making phone calls on every reported female of childbearing age who may be pregnant. And we try to ascertain pregnancy status and go from there. Okay, this is the most recent article about missed opportunities for congenital syphilis prevention. And just 2 weeks ago, CDC at one of our grantee meetings presented us with this infographic discussing congenital syphilis, potential congenital syphilis cases averted. And so the bottom line is that active follow-up of pregnant persons is imperative. We need to make sure that they're being treated adequately and on time if we're going to have any chance of stopping congenital syphilis. In Connecticut, these are the challenges we have with preventing and detecting syphilis. We still have a really persistent issue with clinicians not calling us. We made congenital syphilis a mandatory reportable category 1 disease in 2023, and we still have not gotten any phone calls from clinicians to the department when they suspect congenital syphilis. We are also having a lot of issues with laboratories that are not reporting properly, and it is a situation that we really can't make much sense of. But I'm presenting it here so that perhaps I can notify another batch of clinicians licensed in Connecticut on the importance of talking to us if you suspect congenital syphilis. So this is our Connecticut definition of potential congenital syphilis cases averted. And all that really means, I'll take you through the schematic, is that of the 34 pregnant females in 2022 that were reported to the department or that we found by virtue of backtracking on a lab report, of those pregnancies, the diagnosis for most of them was late latent or unknown duration. And unfortunately, if these moms were not treated appropriately, if they had no prenatal care, or if they were engaged in substance use, those pregnancies resulted in congenital syphilis cases. The averted ones, these are the pregnant females that we were able to either reach out to or confirm that their provider had appropriately staged their syphilis and treated them on time for it. So in summary, we're still seeing in Connecticut, chlamydia highest prevalence still remains in 15 to 24-year-olds, females more affected than males. Gonorrhea continues to affect 15 to 24-year-olds disproportionately. Syphilis still increasing, syphilis of all types increasing in females of reproductive age. And I already covered the significant issues with significant things associated with our congenital syphilis cases. So this is my fancy slide to just say this is all the things that we're dealing with. And if you have additional questions, please refer to the slide handouts. And you please contact our department if you need to get syphilis titer histories. Thank you very much for your time.
Thank you, Eva. That was great. Dr. Dunne, you should be able to share and proceed.
Yep. Great. Thank you for that overview. So I'm going to be talking to you about Syphilis 101. So excited that you're here today. So we have 40 minutes left. So really, I'd like to try to save 5 minutes for questions. What I'd like you to do is, since we're not evaluating this session or any of the sessions until the end, I would really appreciate it if you have a little piece of paper you keep out during each session and you jot down like things we should keep, things we should add, things we should drop, because this is a grounding talk. And for those of you who are more experienced, hopefully this will be a very reinforcing overview of what you thought you knew and that you know it. And for others who are just starting, giving you a foundation. But we want to develop other content and Syphilis 201 and beyond for areas that we need to blow out and develop more. So you're going to forget about it if you don't jot some things down as we go, and we definitely want your feedback. So please keep that handy. You could do that for all of the talks. So I do have some photos along the way. I'll give you the warning before they come up, but they're important for understanding some of the manifestations. So thank you for going over the epidemiology already. So I won't be talking about that again, but we'll talk about staging. We'll talk about testing, and we'll talk about treatment. So start to kind of write down what you wish you knew more of while we're going through, and hopefully have some time for questions. So this is a prototypic case that we will come back to apply some of the things that we're going to talk about today. But if somebody's coming in with an ulcer, what's on the differential diagnosis? How should we test for it? How can I interpret the testing? And how do I treat? And this may be kind of more of an apparent manifestation of syphilis. And I understand that there may be some dentists out there and people who are in neurology or dermatology. And as you'll see, syphilis can show up in a number of places. So a lot of times people think about things that might be sexually transmissible if somebody comes in with a genital lesion, but they might not think about it so much if they're having patches of their hair fall out, or they're having ringing in their ears suddenly. So it is really great that a lot of different people are here, because you are thinking about taking a sexual history and remembering about the differentials, and syphilis can be so challenging that way. So if we don't kind of really think about taking a sexual history, it won't make us think, should we consider things that could be sexually transmissible on that list, because it can be so important for personal and public health to make the diagnosis promptly. All right, so we'll go through clinical testing, treating, and a little tiny bit about reporting. So just a couple of, just like one general slide before we get into the clinical. So how can you get syphilis? Mostly we think about getting syphilis through more intimate exposure. It doesn't have to be penetrative sex. It can be close skin to skin contact, depending on where the lesions are, how intact the keratinized epithelium is. If you're having primarily putting your mouth on a partner's genitals, you can certainly get the first lesions in your mouth. But as we've just talked about, that there's issues with vertical transmission. Deep kissing has been reported to be able to be transmitted. And as you know, we screen our blood for syphilis, and you could auto-inoculate if you're doing some work in the lab on syphilis. So, but we're typically talking about the first two categories today. So when are people infectious? And sometimes this will come up when you are then going to counsel people, if you'd make the diagnosis and treat them, like how long should they remain abstinent before they might be able to be with partners again. And I'll just jump to that and say we usually tell people if they're being treated during a infectious stage, that they are considered to be non-infectious after a week, as long as they're partners, they're not going back to untreated partners. But we consider forms of syphilis to be infectious if they're what we call early syphilis. So that's your primary lesions, which we'll talk about, the primary bump that then ulcerates, which we call a shaker, or when there's more systemic manifestations of skin rash and the alopecia. And really anytime in that first year, because if it's untreated, you can kind of have subclinical waxing and waning of lesions that can still transmit. After people have been infected, even if they're not treated, if they've been infected for more than a year, they're thought to be less infectious, although there still is a trailing bit of infectiousness. After 4 years, it seems to be really not likely at all with respect to whether you're going to be able to transmit. And epidemiologists who look up partners take these things into consideration about how long somebody's been infected and when they might be infectious. If you do have contact with somebody who's got infectious syphilis, how long does it take to kind of get it, either to convert your blood test to be positive or to show up with a manifestation, a clinical manifestation? So the incubation period is anywhere from a week to 10 days up to 90 days. And typically the 90 days is really the upper limit of when we would say that your blood test, had you gotten exposed at that time zero where you were concerned, 90 days, if your blood test has not turned positive, then you probably didn't get it. So it can take a while for serologies to convert. All right. So this is a public health poster when syphilis rates first started to go up in men who are having sex with men, and this was in the San Francisco area, as you can see by the Castro signs, that was trying to educate people about the stages of syphilis. So you don't fool me, sores followed by a rash. So here's sores being followed by a rash. So keep that in mind. We'll go over the kind of the stages of syphilis using some a little timeline that I'll keep throughout the whole thing, as well as some photos. We'll talk about the differential diagnosis at each stage. But again, really for infectiousness purposes and also for treatment purposes, we divide syphilis into early and late. So early is either the primary, which we'll talk about, the lesions, the ulcers; secondary, the more systemic manifestations; and early latency, which is in that first year, as opposed to late disease, which could be asymptomatic, which is late latent. So you've had it for more than a year, you've been exposed more than a year ago, and then later manifestations that can manifest in a number of ways, which we'll talk about. All right, so I have a variety of photos because it's just important to recognize kind of a range of way the lesions can look in different phases. So this little timeline up in the upper right is just keeping you oriented to where we are. So we already talked about if you get exposed, at the incubation period with respect to symptoms especially is usually get about 3 to 4 weeks, even though we might give up to 90 days for a blood test to turn positive. And then we're going to follow this along here. So right now here we're in primary. So first you're going to get a bump when the spirochete is inoculated through sexual contact, which usually includes a little bit of friction, typically on maybe a mucosal surface, but it could be a non-intact keratinized epithelial surface. And then it eventually ulcerates. The organism recruits slowly plasma cells, lymphocytes, and since they're not really neutrophils, there's not a lot of the neutrophilic damage that usually then results in pain and discharge, as we can see in Haemophilus ducreyi, which causes a genital ulcer disease called chancroid. That bacteria, Haemophilus, makes gram-negative, as a gram-negative, makes white blood cells come in that are neutrophils, and it's much of a quicker response. It's more robust. It gives you pain. It gives you pus. But this spirochete doesn't have a lot on its surface, so it's kind of barely being noticed. So it's more plasma cells and lymphocytes. And so the ulceration really then recruits a lot of collagen. So it's very firm. It's not tender. So the classic lesion of primary syphilis, called a chancre, is painless, typically, with then regional painless lymphadenopathy. And that could be whether it's in your mouth, whether it's in the genital area, vagina, anal, etc. So the differential at this point for a ulcer, especially if it's a genital ulcer, would be genital herpes. That's the big differential in the United States, but that is typically shallow. If you picked it up and squeezed it, in addition to the person saying, ow, it wouldn't be very firm or indurated. And some of these other things are just really not very common unless somebody's a traveler. So the big differential is going to be non-infectious versus herpes in the United States. So here's a picture in the lower third of the labia. And this is a very typical place for patients with labial lesions to get a primary lesion. Here's a cervical lesion that you can see on a speculum exam. And you can see here's a penile lesion, and you can imagine the firmness of that. But just to kind of show you the range, so this would be maybe up here where my arrow is, and I'm not sure if somebody can tell me if you can see my arrow moving. Amit, maybe you can tell me.
Yeah, it's small, but we can see it, yes.
Yeah, so this, you might think, well, that doesn't look classic. It's not really ulcerating, it's not heaped up, but this could be an earlier lesion. It starts as a papule and then it ulcerates. So, somebody who's sexually active in the last 90 days, whether they had oral contact or penetrative contact with anal or vaginal, have that on your differential. And here's a couple of lesions here that are small and kissing, so they can be multiple. Here's one right at the introitus of the vagina. Here's one that's maybe kind of starting to heal up on the shaft. So these could be all in various stages. So they're not going to necessarily look like they're in the book. So especially for the dentist here, but for everybody else who are seeing patients, they might not have anything in the genitals, and they could have a primary lesion in there. mouth. So that might be where the primary point of contact was. So you can see some on the lip, some on the tonsil, some on the tongue. These can all be consistent with primary lesions. So taking a sexual history to know if somebody could have been exposed, then can be on your differential and you can test for that. And this is a perianal area. So these are all primary lesions, excuse me. And even without treatment, they can go away. And 2 to 6 weeks later, the organism starts to multiply and kind of overwhelm whatever host immunity was starting to develop that made the lesion, primary lesion, go away. And then typically you get hematogenous dissemination of the spirochetes to the rest of your body, and it can have any number of manifestations at that point. This is where really there's so many things it can do, but the most common things it does is have a skin rash. It doesn't always have to. On the next slide, we have some other manifestations that can occur without a rash, but this is the most common, and they can be really subtle. People have had syphilis before, just come in with a couple of spots, and they say, I know when it looked like this before it was syphilis, and maybe it was, they're presenting earlier. So typically it's not itchy. And I've shown kind of how it might look on lighter skin versus darker skin. So this is the sole of the foot, and you can see they're kind of macular, copper colored, kind of some stria going through them on the foot. Here on the face, they talk about these nickel and dime lesions because there's maybe a little bit of a kind of an indurated, kind of pseudovesicular look almost to them on the face. So this is how it might look on hands and on face. And then on the trunk, it could be anywhere from a few lesions to a number of lesions. Really, almost anything they say, except for maybe vesicular. The lesions that are up here in the upper left, I would classify as what we would call Louis maligna, more ulcerative. So this is like malignant Louis, why some people might have more of an ulcerative manifestation in the secondary stage. It's hard to know if it's a virulence factor or a host factor, but keep syphilis on the differential for this as well. And then you can see this is patchy alopecia or moth-eaten alopecia in the scalp. We've definitely had patients coming in with, this is their only manifestation, that this is what they're concerned about. They might see the dermatologist, they might see the primary care person, and thinking about secondary syphilis and taking a sexual history. Now that we've gone incubation period up to 90 days, 2 to 8 weeks later, that means really being sexually active with anybody in the last 6 months. By the time they get to secondary, would be a good sexual history to find out about. So in addition to rash, there's a lot of generalized symptoms, as you see here. You can have generalized lymphadenopathy, and then you can have isolated or along with the cutaneous manifestations. Hepatitis, the typical pattern for that is a cholestatic hepatitis with your alkaline phosphatase much out of proportion to your transaminases, although we have a poster ID meeting today that Dr. Atra and Anna are at of a patient who really came in with AST and ALT in the thousands and an alkaline phosphatase of 300 something, who ended up having syphilis. Renal involvement, and as we'll talk about, and as I've been hopefully showing you, and I'll point out on the timeline, you can get neurologic involvement very early on with syphilis. You can, that's been proven that very early, even in your primary lesion, spirochetes could have already gone to the nervous system. It's a very neurotropic bacteria. So you can start to have symptoms and symptomatic neurologic involvement either right before you get secondary or during secondary. So we'll talk about some of those symptomatic early neurosyphilis manifestations. So we talked about that you can have oral manifestations if your primary point of contact with somebody who's infectious is in your mouth. But even if it was and that went away on its own, or if your primary lesion was elsewhere, during secondary syphilis, when the lesions are disseminated, you can get manifestations back in your mouth, in the oral cavity. And so these are some pictures of mucus patches. It can look like these rounded lesions on your tongue, or these kind of snail track looking things in your mouth. So you always want to have people open their lips and kind of look in the palate and look in the posterior pharynx for these kind of lesions. And you can get mucus patches in the scrotum, on the shaft, on the penile head. Again, even if that wasn't the primary place where they're inoculated. And you really have to kind of really be looking intentionally to find it there. You might have to really kind of spread the skin out, potentially tangentially use some good lighting to make sure you're not seeing some subtle manifestations there. And these would all be manifestations of secondary syphilis. And as you'll see, your blood test should be positive during that stage. Another manifestation you can get on your skin in the secondary stage is called condyloma lata, which just means heaped up white lesions, typically anywhere where there's a lot of moisture. Really common for practitioners to kind of then maybe if they're looking the genital area to say, oh, it looks like you've got warts, because it's like there's multiple lesions kind of look a little bit warty. And the difference would really be, as you can see in this upper right-hand corner, warts would have more of a narrow stalk. They're typically not going to be white looking. They're going to be more flesh colored. So these are broad based. They go straight down to the skin, flat, moist, kind of white. So if you're thinking warts, unless they look super, super classic and narrow, definitely keep condyloma lata on your differential, and the fact that it could be syphilis, because there's lots of treatment and public and personal health ramifications of making sure you test for that and rule that out. All right, so here we are up on your timeline. We went through secondary. Neurosyphilis can occur at any stage. Even if you don't do anything at all, people can resolve those symptoms, and it'll go into a period of being asymptomatic. And most people will say that way. As you can see, only 30% of people historically would go on to have later disease. So 70%, 80% of people probably then just either they clear it, we don't quite know, or it's just their immune system keeps the upper hand and they don't really get any problems with it. So latency is defined as early or late based on you can diagnose it as early latency of less than a year duration if you are able to fulfill any of these requirements. I'm not going to belabor this point for time reasons, but if you can't know for sure whether it is early and you can't know for sure whether they had any of these unequivocal signs or symptoms of primary or secondary in the last year, we just usually presume that it could have been there for a long time, because the difference in treatment is basically treating for early latency is 1 shot of penicillin and treating for later is 3 shots. So we err on the side of being more conservative if you don't know for sure. So for the few people who go on, and this is really where I'm not going to spend a lot of time talking about late manifestations, although I'm going to talk about neurosyphilis a little bit. There are cardiovascular consequences, including aortitis, coronary artery disease, and some inflammatory lesions that form around a few residual organisms that can have symptoms depending on really where those inflammatory lesions are. They might not be bothering you if they're in your bone or in the skin, but if it's in the conducting tract of your heart or in your brain, you might get symptoms. But I definitely want to just alert you, because a lot of times people feel like neurosyphilis is synonymous with late syphilis. And to restate, if you get an infection up here at the top, we feel like probably most people, when they do spinal taps on people with early syphilis, get treponemes up there, but will spontaneously clear or will clear with a stage appropriate dose of penicillin. But there are some people who have spirochetes that will persist, and they may have asymptomatic. If you did a low LP on them at that time, you might find spinal fluid that looks consistent with neurosyphilis. But there are some manifestations of symptomatic manifestations of neurosyphilis that occur earlier and some occur later. And this is a really good review. This is also, you could find an up-to-date on which symptoms come up early and versus later. But we'll talk about early symptomatic neurosyphilis, which can really be within just a matter of months of your primary infection, versus stroke syndromes, which are typically more like months to a couple of years, or these later symptoms of paresis and tabes dorsalis, which are going to be more on the order of decades. So what would be some of the symptoms that you should be watching out for, both for if somebody comes in and they have one of these, that you should think of syphilis, and vice versa, if somebody comes in with a positive blood test for syphilis and you're trying to stage them appropriately, you want to make sure you ask some of these questions. They're really they're it's not an infinite number of possibilities for the ones that occur earlier. They're mostly ocular. I would say 50% are ocular, with uveitis being and chorioretinitis being the most common, but also otic. We see quite a few people reports of people coming in the emergency rooms with sudden sensorineural hearing loss or sudden ringing in the ear, and maybe getting referred to ENT, and people not really like thinking that syphilis could do this. So probably about another 25% of that, and then cranial nerve palsies, the worst headache of your life, and you see that there's white blood cells when you do a spinal tap. So these are some of the things, if they come in, you should think of syphilis, or if they're coming in with a positive syphilis serology, that you would ask about. And later diseases, I won't spend as much time on. You can look these up, but do keep in mind that can manifest decades later with being irritable, having personality changes, impaired memory. There's some specific pupillary findings. And then for posterior column involvement, that it can affect your gait. You can have lancinating sensory pains and a funny gait. And if you would like to look up in the New England Journal of Medicine, if you Google New England Journal of Medicine video and put in Argyll-Robertson pupil or syphilis, there's a really nice video of a patient in London a couple of years ago where they have a good demonstration of his gait and of the Argyll-Robertson pupil. So a video would be worth 1,000 words there. I did a curbsiders a while ago, so this is a great graphic and maybe a worthwhile episode reviewing if you want to just go back and review those stages more. So let's go on to talking about testing. So the thing I want you to keep in mind for testing is we'll talk about like which blood test to use first, but the bottom line is you need both non-treponemal or lipoidal tests and treponemal specific tests. You need both different kinds of flavors of tests to make the diagnosis. But before we get there, just remember there are some times where you might be able to make the diagnosis directly with if you have access to dark field staining or if you have an enigmatic rash or lesion, and syphilis is on the differential that they can do an immunohistochemical stain specifically for Treponema pallidum. So there are ways for you to test for syphilis directly, but we are usually presumably that you are using indirect or kind of blood tests to look for antibodies that are being made in the presence of syphilis, either specific to syphilis or non-specific. So you really, you have to use both, and it's the kind of the combination in which you use them that might differ from your sites. So you might be starting with or using in a different algorithm non-treponemal tests, and the new terminology, they're really trying to get away from non-treponemal tests and call them lipoidal tests. This is your RPR or your VDRL, and it is non-specific. We don't really like to use non-treponemal anymore because they are elicited in the face of a treponemal infection. They're just non-specific because there can be biologic false positives because there's other conditions that can generate antibodies that would show up as positive on this test. But it's important because it is typically a titerable test, so it can be really quantitative. And the higher titer usually reflects the stage of the disease, and you're going to use it for monitoring. And then there's the treponemal specific tests. The older ones like the TPPA, treponemal pallidum particle agglutination test, we'll still talk about in our algorithm. But most of the people who are starting with the treponemal specific test are starting with that in your workflow because there's new automated specific treponemal tests. We call them on our Epic, it's treponemal antibody. And that's just because there may be any number of manufacturer types that we swap in or out from one year to the next. So they just keep it very general. But any point of care tests that you're using in your sites as well, those are typically treponemal specific. So they're more specific and they're detecting antibodies to treponemal pallidum, but they won't necessarily distinguish a new infection from an old infection as they typically will stay positive. So you'd need both flavors. And one thing to know about which one comes positive first, to recognize if the treponemal antibodies, whether you're using the TPPA, which is the non-automated, or a TREP antibody that's automated, you typically turn positive first. they're more likely to be positive earlier on. Like, so if you have somebody who's coming in with a new lesion, hasn't been there that long, if you're in a site that starts with the lipoidal, like an RPR, that still might be negative, and the treponemal ones would be positive early on. But as you can see, the treponemal positive comes up early on, and it stays positive whether you treat or you don't treat. Whereas the non-treponemal tests or their lipoidal tests come up maybe a week or two later, and they would typically respond to treatment, but they can come down, on their own even without treatment. And in 25% of people, they can really totally become negative. So people have been infected for years won't necessarily still have a reactive RPR or a VDRL and still could have latent syphilis. I know this is probably where a lot of people would like me to be slowing down. So to have another whole session on testing would be good. But I'll just walk through the traditional algorithm and the reverse algorithm, and then we'll just go on to treating. So for those of you who are using the traditional algorithm, that means you kind of start with this lipoidal antigen, the non-specific RPR or VDRL. And if it's positive, you have to make sure it's not a biologic false positive. Excuse me. So if it's negative, we had stopped before. But if it's positive, you then confirm with some sort of treponemal specific test that this positivity is indeed due to syphilis. And then if they're both positive, you have syphilis and you need to stage them. The difference with the reverse algorithm is that you're starting with the treponemal specific test that's automated. And if it's negative, you're done. But if it's positive, you have to then follow up with a lipoidal test so you can see how active it is. And if they're both positive, you have syphilis and you still need to stage it. So they're really not necessarily helping you necessarily with the staging. They're just confirming syphilis. If they're discordant, so the screening specific test was positive, but the RPR or the VDRL was negative, your lab will automatically cascade to do a tie-breaking second treponemal test that's more specific. And if it is also negative, the original treponemal test was probably a false positive. The two things I'm going to just point out on the slide before we go on is to say that the one benefit of the reverse screening algorithm is that you, first of all, if somebody's got a very, very early lesion, you might have missed it if you just started with a VDRL. You could always bring that person back a week later. But also for people who might have really late disease and their RPR titer really has become negative on its own, and they could have latent disease that was never picked up, we're really able to find more of those people starting with the treponemal specific test. And most labs go all the way through this cascade, and they give you an analysis of really how to interpret the various results as you go along. The one reason why you might have somebody who's reactive treponemal test, and if they were negative for their VDRL and you had to go to this tiebreaker,
I would include gay guys.
If it's positive, it may be that, again, it was an old treated case, so their RPR is not positive anymore. It could be that it's an old untreated case, and you would just ask them, have you ever been treated before? Or again, it might be that it's very early, and you would need to take a sexual history and see if they've been exposed in the last 90 days and potentially treat if you have a high suspicion or bring them back. If you want to find out more about testing, the CDC for the first time in years put out a new recommendation on all things lab testing, terminology, all the algorithms, etc. So take a picture of that QR code and you can find out everything else you want to know about testing. All right, so that confirms the diagnosis of syphilis. So really then, what are you supposed to do with that information? So you have to interpret the algorithm, as we just talked about. If they're both positive, which either direction you started with, you have syphilis, but then you really have to stage the patient so that you know how to treat them. Then you treat according to that stage, you report, and then you do the follow-up. So staging, really, we've gone through the stages now. We've talked about, primary, secondary. So you might need to ask about any of those signs or symptoms, ask about last contact so that you might be able to figure out if it's been a certain number of days, what kind of stage you might suspect that they could potentially be in. And then make sure that the physical exam is head to toe, as you've seen, where all the lesions can include. You really do need to look at their backside if they're having anal contact, and can't really rely on any self-report. And remembering to do the good neurologic exam and ask them about signs or symptoms to make sure that if they are truly asymptomatic and they're latent, that's fine, but we don't want it to be misclassified because it was not a thorough history and physical. Little reminders like this, we have this in our HIV clinic. It can be really useful for our PA who fields a lot of the positive serologies, that we're not just presuming that it didn't look like if they had a sore or a rash that they must be latent and have no symptoms, of really having some prompts to ask the questions to make sure we're not missing any of these symptoms, both early and later at manifestations of neurosyphilis. So that could be useful for you. All right, so we've talked about syphilis, the organism. Now we're going to talk about the treatment. Anybody can guess what I'm holding up? It is our old friend penicillin. This will go quickly, but I'm really hoping to be able to get to save my 5 minutes for questions. So, as I mentioned, we divide treatment really into early. So that's your primary, secondary, or early latency. If you really can feel secure that they fall into that early latency bucket, that they have no symptoms, but they have some of those reliable, confirmatory, good story that they had a sign or symptom of primary or secondary syphilis in the last year, or been exposed to somebody, or converted their blood test within the last year. They can all have one shot of benzathine penicillin, whether they're HIV positive or not. So you can do that, or you can use 14 days of doxycycline. Maybe if there's questions about penicillin shortage, some of our friends from the public health department can hop on. But I've been told that within the month that is supposed to be really more or less resolved. Otherwise, in the meantime, we've been trying to make sure we maintain the benzathine penicillin for our patients with pregnancy to make sure that they get treated. So doxycycline is an alternative if you don't have benzathine penicillin, or if they have a really severe penicillin allergy. If they have latent disease, so more than a year, or you're not quite sure, or if they have a tertiary manifestation, it is not neurologic, we give them 3 weeks of benzathine penicillin, so separated each week by 3, not going more than 9 days between doses ideally, or you can give them 28 days of doxycycline. There's a great new review in OFID, Open Forum Infectious Disease, in March of 2024 that has a big meta-analysis of all the other comparators that have ever been used against penicillin for different stages of syphilis, if you're interested. If you have otic disease, or if you have ocular disease, or any neurologic disease like cranial nerves, stroke syndromes, aseptic meningitis, we use IV penicillin to make sure that the treponemocidal levels are high enough in the CSF. And if you don't have neurologic disease, but you have something that's cardiovascular or a gamma, typically we recommend doing an LP to make sure there's no concern for neurosyphilis. And if that looks totally normal, tertiary disease can be treated with as latent. This is the STD23 form. So we talked about 2 tests are positive. You stage them with history and physical. You treat them according to their stage in the CDC 2021 guidelines. Then you report. This is a state is going to, lab is going to report their positive serology, but they don't, the lab doesn't have all this great information that you're able to say to submit to the state what clinically, what stage did they have when you treated them? What did you treat them with? Because the state really wants to see the lab report, and they want to see this from you, and they want to see that they match and they were treated appropriately, so they can prioritize their work. So remember, there's dual reporting in Connecticut, and you really want to say both. All right, this is like you're following along in your head now. You're following along in the head. Painless ulcer. What was the differential diagnosis? It included herpes. So you're going to want to make sure you always take the sexual history. You want to take a travel history. Are there going to be some of those less typical genital ulcer diseases in the differential, like chancroid or lymphogranuloma venereum, and being able to examine it? So you're kind of increasing your pretest probability about if it feels clinically more like a syphilis lesion, it seems clinically more like a herpes lesion, because at the end of the day, you're going to treat what you think is more clinically likely. And you can't guess by looking if they have herpes or syphilis. Sometimes they have both. So you should just routinely make sure you check for syphilis and for herpes. Even if you have a higher suspicion of one versus the other, you can treat for the most likely. So do a PCR on your genital lesion. If you can do a dark field, otherwise you're going to rely on your blood testing and interpret it as we talked about. So always do that. Here's some pictures of chancroid. You can see it's much more virulent kind of looking and pussy looking. It's really kind of typically painful. Reach out and call us if you feel like you have something like that. There's only maybe 5 cases or less than that in the States every year. So you're going to treat the most likely diagnosis. If you think it looks very suspicious for herpes, you could start them on a treatment for that. Certainly have them abstain until you know. But as I mentioned, especially if you're starting with an RPR or a VDRL, which can take maybe another week or 2 to turn positive. If somebody's coming in with an early lesion and the serology is negative and the ulcer hasn't been there for very long, have them come back in a week and repeat it so that you can get some diagnostic certainty. And then if you are going to treat them empirically and they just have a painful lesion, which of these, this is your pop quiz, I think last slide, just to make sure that you know what we talked about. It's not 7 days of doxy, it'd be 14 days of doxy. It's not ceftriaxone, not azithromycin. So we're really able to use just 1 shot of penicillin for early. Just reminding them about the abstinence for 7 days. Please report. Please get the partners in. Here's this number that you can call at the state if you don't already have it. If you want to have them be able to talk to the partners for the patient, they'll call your patient and get partner information so that they have good expertise to do that for you. So I think that is all we have. Sexual history taking, knowing about the epidemiology, making sure that you do a general workup for genital ulcer diseases. It's always a good opportunity to make sure they're not HIV infected, or if they are, and think about ways to keep them HIV negative. And don't forget to report so we know how many cases we have. There's this last slide again for anybody who came in late, that if you have questions about tough cases, that you can utilize this group, which has got a really great brain trust, and we always really like wrapping our heads around difficult cases and helping you out. So let me stop there.
All right, thank you so much. Thank you to both the speakers. There are some questions in the chat that is great to see. And, for people who want to just hang on, even if we are past 1 p.m., we can answer some of these questions. So I'll try to bundle them up. First is I believe for Ava, is, the initial, I think the 90s epidemic was thought to be due to the crack you said. So what might be explaining the current surge of syphilis? Any thoughts?
Yeah, so in advance of this, I did review what current literature is available, and really the jury's still out. We just don't have enough years in this current surge to really determine what is going on. We do know that there are definitely geographic differences. I put something in the chat, which is a link to the latest CDC vital signs regarding congenital syphilis, but I think it's really too early to speculate, what the cause is. I know that we are tempted to think that there is an association with the opiate epidemic, but the fact is we see in Connecticut that among our persons who gave delivery at a hospital, that was like their first time anyone knew they were pregnant, all of them had polysubstance abuse. So there's not a single, we can't say, oh, it's the opioid epidemic. No. The crack epidemic was a little different in that, there were very, very consistent data collection about what was going on with the failure of the public health infrastructure and also the healthcare infrastructure. across the country at that time period in our country. So we're looking at something different. It's similar.
Yeah.
The peak is similar in terms of numbers, but as far as what the actual causative things are, all we're going to do in public health right now is focus on what we can actually control. And that is on making sure that moms get prenatal care. And that, that clinicians are astute enough to know that they need to actively follow up and make sure that pregnant women are getting that care and getting treated on time and appropriately. Thanks.
Great, thank you. I agree. It's tough to say why a single reason, but probably multifactorial. Okay, a couple testing questions, which we expect always, Dana. So for you, one is an non-reactive RPR considered the starting point for determining a four-fold increase? So what would be 1 to 2? Would that be a four-fold from non-reactive? And then also in the same line, the question is, so are we suggesting we order both treponemal and non-treponemal test from the onset if syphilis is suspected?
So if syphilis is suspected, your health setting in which you work has already made the determination, and that the new document that I had, the QR code, is has a nice table about like, why might you choose the traditional algorithm versus the reverse algorithm? And it has to do with how busy your clinic is and who's funding it and who your patients are, so that make all those differences. But so your setting is going to be determining what test you send first. But you're sending a tube of blood to them, and they're making the decision what they start with. So if they're starting with the treponemal specific test, you don't have to send anything else, because if it's positive, they will keep that same blood, and they'll reflex it to that second test without you having to order anything different or more. Same thing with the other. They'll be able to use that same tube of blood you sent and just reflex it and put it through their cascade. With respect to the titer going up and where a fourfold increase would be starting from, typically when we're following RPR titers, it's in, you make the diagnosis. So presumably if the treponemal antibody test was positive, the screening initial test was positive, and your RPR was negative, and as long as we don't think it was a very, very, very early infection, you're probably, as long as the confirmatory tiebreaker test was positive, that TPPA, presuming it's older, either old treated or old untreated disease, and you don't really have an RPR to follow at that point, right? But say you're treating somebody who had active disease and their titer was positive at some point, their RPR, and it was going down, and it went down all the way to non-reactive. Are you saying, so even if it only goes down to 1 to 4, from 1 to 64 and stays down and stable, that might be fine. If it goes all the way to non-reactive, that can be seen over 6 to 12 to 24 months. But certainly if it goes all the way to non-reactive, then it goes back up to 1 to 4. They could have been re-exposed, most likely. So it's a twofold, 2-tube or 4-fold dilution increase where we would worry that they either might have gotten re-exposed or they failed treatment, and we would be concerned that we had to think about neurosyphilis or some other protected site. I'm trying to answer some of these in the chat.
Yeah.
But my spelling is poor. Any other priority questions that people have? Because I'm also able to stay on afterwards if that would help.
I think the last one is if the patient asks for VD screening. So, Maureen, is that something? Can you clarify VD, or did you understand, Dana?
Venereal disease, like if they're looking for testing, is that?
I would guess that's what it is. So yeah, would you add syphilis or only if they are at risk by history?
Yes, especially if somebody comes in looking to be tested for all the things, that would definitely be something that you want to include. Even if they said, if they said I'm not sexually active, I think if they're asking for testing, they want to know. They might not be feeling comfortable telling you everything. So I would include syphilis testing. Yeah, and it's not like an USPSTF task force recommendation to do routine screening in non-pregnant people unless they are men who have sex with men right now. So really making sure that you're asking your patients routinely about who their sex partners are, so you can make sure that it's somebody who you might suggest screening for would be important.
Yeah, I think to add to that, when I speak to many of the urgent care providers and colleagues, I think one of the reasons the question comes up is it needs a blood draw, whereas the other STIs are often checked. I mean, the HIV also needs a blood draw, but other STIs could be urine test, and so that creates that extra step. Not all places may have that access. So yeah, but I think with the rising numbers of syphilis, someone is coming for STI checkup. I would encourage, as we all do, to look for syphilis as well, and potentially HIV as well.
I welcome anybody to reach out to me for any questions, but also to take a little note and keep it for the evaluation at the end to say where you want more detail, so that you have like kind of that quick 35-minute rocket paced overview. Just kind of got everybody to on the same page. But I know that there's a lot of questions and I really don't want to leave any unanswered, but any that we can blow out in future sessions, please let us know.
Do we have your email? That's a question. That's great. That's a good question.
Dana.Dunne@yale.edu. And I was just thinking, I have these cute little spirochetes. Maybe I could make a crown. But I do love syphilis. I really like to be helpful. All of us on the call really like to be helpful. So please, please don't. I'm so happy everybody was here today.
Okay, yeah, sorry if I missed any hand raise. I tried to look in the participants, but if there is no outstanding question, yeah, that's great. I hope people can continue to attend the series. Next week it's congenital syphilis. There were already some questions for it. We purposely let out today, so do definitely come in to hear more about the congenital syphilis, some interesting cases, the treatment options, etc.